Now what I want to do is create a channel, so I'm going to go all the way to the anterior third of the vertebral body before I place the vertebral or contour osteotome. I'm going to advance the right one now. I know it's probably difficult to appreciate this, but I can appreciate the two needles. There comes the one advancing there. Now I've created these channels. I'll back them up to the posterior third of the vertebral body. This by simply screwing back or unscrewing. Okay. This is the contour osteotome. It's a nightingale tip. What I found is that if I put my finger right near the bend, since it is very stiff, place the tip in, turn up, and a little gentle push, and down it goes. The other trick is to hold the clutch plate up until it reaches down to the threads of your cannula. Turn the whole device until it seats, and then your clutch plate slips down over the hub. And so we're in position. And on the lateral view, you'll see that the osteotome is not deployed at this point. And what we do is there's a green hub, which is the proximal hub, an underfloral. You can watch it move forward. And here we come. And there it's deployed. You can feel it pop through. And I go until I hit that first bend. Once in that position, you can see I'm in good position, well positioned between the superior end plate, inferior end plate. And I know from my pictures that I believe the fractures towards the superior end plate, as that's the one's compressed. And we'll turn a full 360 degrees. Once is enough, but certainly two is adequate. A half a turn on the green hub or the proximal hub. You can see it's moved forward a little bit. Repeat the same process. And on the top of the silver hub, there's a narrow, so you know that you've gone completely around. But I think you can tell that from just flarrowing. Another half turn. And repeating the same process as we move forward to the anterior third of the vertebral body. Once I've reached that far forward, what I have done is I will repeat the process coming backwards. And you'll feel that I found that it's much easier the second pass back. In this way I've created a void or a cavity for the cement. Once I get back to that angle, I will just back the needle up, pull it back into my needle, and now I can safely take it out. Again, using the same process, pull the clutch plate up, unscrew it from the needle or the cannula hub. Always inject in the lateral position. And there you can see the cement beginning to ooze out the tip of the cannula. And I just go slow. You can see how it's created a cavity. There's no rush. And you can see I'm about probably halfway back. Coming back to this part of the vertebral body now, back along the needle track. Beautiful cement distribution. I'm going to go check the AP view. So you can see it's how it's centered around the needle, maybe a little bit starting across midline. But I always inject in the lateral projections because I'm most concerned about going back towards the spinal canal. So go back to the lateral projection. This always allows a little bit more time for that cement to set up. Again, back to AP position. I think that's really good distribution of cement on the right side, so I'm going to switch and go to the left side. It doesn't take me very long, as you can see, to do both needles. And then I know I'm getting good cement distribution. Now it's difficult to see the cement coming out on the second needle because you've already got so much cement on the other side. So I'm watching the margins to see any changes along the contours. I've found with this vertebral augmentation device, the contour, that I've been able to get more cement in. I'm much more confident about having control of where it goes. Let's go back to AP. Beautiful. That's great cement distribution. And I think that is adequate. Let's go back to lateral. Back off the pressure. We've got a total of 5 cc's of cement in. Again, lateral position. I'm going to back the needle up just a little bit, let this cement I push out fill that track. I know it's hard to see it probably on the camera, but I can see it. When we back the needles out, they are threaded so you can unscrew them. Sometimes it's when they've been in so far. You have to pull them back a little bit to re-engage the track to the pedicle. And I always bring them out a little bit slow to make sure that the cement is not drug along with it out the needle track to avoid cement coming back out into the posterior soft tissues. Needles removed. And I take a picture, nice cement distribution.